Hello, this is Peter Soukas. I am the Director of Vascular Medicine and the Interventional Peripheral Vascular Lab at the Miriam and Rhode Island Hospitals in Providence, Rhode Island. I'm also the Director of the Brown Vascular and Endovascular Medicine Program and Associate Professor of Medicine at Albert Brown School of Medicine. Here's an example of a patient with multi-level disease where there was severe calcification in this proximal to mid anterior tibial artery. And you can see a 3 millimeter IVL balloon was easily delivered post-predilatation, and after 140 pulses, a 26% diameter residual stenosis with no complications or requirement for a stent, and indeed, I would argue, a stent-like result in that anterior tibial. IVL, now that the balloons have become even lower profile, we find that most often we can cross these lesions without any predilatation, which is great from a cost savings and a time saving standpoint. In patients who have impaired outflow, particularly in those patients who have single vessel runoff, this is clearly going to be the best choice with regards to not only procedural safety, again, with no significant risks of perforation or distal embolization, but also from an efficacy standpoint, because we know from histologic studies that the further distally you go down a tibial artery, the more likely you're going to have circumferential concentric calcification. And we need something that can fracture both medial as well as deep wall calcification. And this is the only technology that can do that. So any patient in whom the IVL balloon can be delivered, I think that is destination definitive therapy, not only in terms of getting an acute luminal gain, but also for the theoretical benefit that we hope to have in the future with drug-eluting technologies. Our use of IVL in CLI patients, especially below the knee, mirrored our use of IVL above the knee in patients who didn't necessarily have CLI. When we first started using IVL, we typically would start with an atherectomy device to make a pilot channel and then used IVL afterwards. And what we found was, especially when we did serial IVUS imaging, was that very little acute luminal gain was from the atherectomy device, but the overwhelming majority of it was from the IVL. And so we said, well, gee, maybe we could save some money and save some time and reduce those dreaded complications of perforation and distal embolization by just going to IVL directly. So in the case of a below knee calcified lesion, if we can pass the IVL balloon, then we'll just go ahead and do that as our primary strategy and not use atherectomy, particularly in patients who have single vessel runoff, who have a delicate collateral network that potentially would be seriously impaired with any type of atherectomy and distal embolization. Here's an example of a patient that we took care of in our lab. This was a 91-year-old gentleman with all the usual factors, including chronic kidney disease and diabetes. He had had coronary disease with ischemic cardiomyopathy. He had also had prior VTE with a DVT in his right lower extremity. And he developed ulcers on his hallux as well as on his second, third, and fourth toes, as you can see on the right side of the screen. Pre-procedural CTA documented occlusion of all three infrapopliteal vessels. He saw one of our local vascular surgeons who, after looking at that CTA, said, sorry, nothing can be done, you need a BKA. Fortunately, he came to us for a second opinion. If you look at his baseline angiograms, you can see that he did not have any significant inflow disease, but he had quite dramatic calcific disease of both the above and below knee popliteal artery. And he had an occlusion of his TP trunk and a scraggly, heavily calcified single vessel anterior tibial artery runoff. You can see on the foot shot that there is reconstitution of the posterior tibial artery via malleolar collaterals, but obviously a very nasty set of lesions here. We were able to successfully deliver a 0.014-inch wire and performed intravascular lithotripsy of the popliteal lesions with a 6 millimeter diameter shockwave balloon And this was followed by a 150 millimeter, 6 millimeter diameter DCB. And you can see a beautiful stent-like result with no dissections, no contrast extravasation. And so we then proceeded to the below knee portion. We're able to get a wire down into that dorsalis pedis, and you can see all of that tram track calcifications on both sides of the artery. So very, very severe calcific disease along the entire length of this anterior tibial artery. Because we had such a long lesion length, in this particular case, we elected to use a 60 millimeter long IVL balloon, followed by a tapered 210 millimeter balloon. And you can see an absolutely gorgeous result there with no significant flow limiting dissections, a less than 30% residual. Now, we did try, because this was a CLI case, to open up another vessel. Unfortunately, our attempts to get through antegrade were unsuccessful. As you can see, our wire was subintimal there. So in this particular case, no big deal. We simply obtained ultrasound guided access in that distal posterior tibial artery. And here you can see our wire being delivered from the foot north, and we're able to successfully traverse the PT and TP trunk occlusions from a retrograde fashion. And then we snared that wire, exteriorized it, and then delivered it in the normal antegrade fashion. This was then followed by IVL with an S4 3.5 millimeter balloon, and we're able to treat that TP trunk disease and PT disease, administered a total of 160 pulses with that balloon. And you can see nice restoration of antegrade flow with some residual dissection in the TP trunk, which we elected to treat with a DES, but then the entire remainder of that PT was treated with just IVL and balloon angioplasty. You can see a fantastic result. This gentleman healed his ulcers in less than a month and was rendered completely asymptomatic after this outpatient procedure. So one of the questions that comes up often is, well, what about the cost of IVL? And fortunately, now, starting in January of 2022, we now have dedicated codes for IVL in the hospital outpatient setting and the ASC setting. So no longer should that be an impediment to the use of this incredible technology. Before IVL, what did we do when we had a densely calcified lesion? Well, with trepidation, we would typically use atherectomy, oftentimes with an embolic protection device, particularly in the CLI patients who could ill afford any potential risk of distal embolization. But if you think about the cost of most atherectomy devices, they're around $3,000. And if you use an adjunctive embolic protection device, that's typically going to be another $1,200. But we've now demonstrated, and others have as well, that most often you can get away with IVL alone. You don't need an embolic protection device. And so in many respects, IVL is actually a cost savings to the hospital when compared with atherectomy, either alone or with an adjunctive embolic protection device. And then, of course, the safety margin is greatly in favor of IVL.